Hello, I'm Dr. Omar Bay, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. As usual, we've got another great show for you. But before we get to the main topic, I'd like to talk about caring and sharing. Coming together and giving us your ideas as far as what the show can be about. Tell me what you would like for us to have on the show. www.medmoments.com. You can go in and email me and give me your ideas. Also, you can give me a tweet at MedMoments. It's all good. Just tweet me and let me know exactly what you're thinking out there. We have a great show for you today. We're talking about bariatric surgery. And I have an excellent guest to go through all the details of surgery. His name is Dr. Jordan Garrison, and he is a bariatric surgeon. And basically, I'm talking about gastric bypass. Dr. Garrison, welcome to our show.
Thanks, Omar. Thanks for having me here.
All right. You know, I'm gonna start very basic, just like I always do, because this show is for the community, for education. What is gastric bypass? Just give me some idea.
It's interesting that you begin your show with growing old. One of the things about obesity is that people will die 10 to 15 years younger than those people who are not obese. When you talk about gastric bypass surgery, what you're really talking about is obesity surgery. And there are multiple obesity surgeries out there. There are variations upon the theme. Gastric bypass happens to be the gold standard for obesity surgery. It is the one that has been practiced for 30 years. And with the advent of laparoscopic surgery, or as most people may quote it, laser surgery, this is something that has revolutionized the industry of bariatric surgery and gastric bypass surgery, such that the complication rates are lower than that of having had a appendectomy, which no one would ever hesitate to have if needed.
All righty. You said one word that I think flew over my head, and it probably flew over a few other people's heads as well. Laparoscopic. What are you talking about when you say laparoscopic? Is that what I heard about the robot?
Well, the robot can be employed to incorporate with laparoscopic surgery. Essentially, laparoscopic surgery is like when people say, give me a Xerox copy. What they're talking about, Xerox is a product and copy is the process. Laparoscopic surgery has been linked with laser surgery. A laser is an instrument that just cuts. Laparoscopic means putting 5 or 4 small incisions on the belly, which may only measure a ½ inch, blowing the belly up with gas, carbon dioxide gas, and sticking instruments as well as a camera into the belly. And while we're doing sort of like video games inside the belly, we're performing surgery that way while I'm looking at a TV screen.
So that means that in the past, someone would have to have a long scar.
Yes.
Post-surgery. Now they don't have to have that long scar, or?
Yes. Initially, bariatric surgery was done in an open fashion, in which they'd have a 10 to 12 inch scar extending from their breastbone down to their belly button.
Okay.
Now, by using these small incisions, we have decreased the complication rate. Prior to laparoscopic surgery, people would be in the hospital 4 to 5 days. Now, with laparoscopic surgery, a lot of the procedures you go home the same day.
Oh.
The greatest advantage is the return to work. People return to work within 1 to 2 weeks. With open surgery, with the laparoscopic surgery, sometimes they go back to work within 3 to 4 days.
Oh, great. Now, let's just step back. What classifies a patient to need, or would put them in a category that we would even consider doing this kind of surgery on that particular patient?
Bariatric or obesity surgery, or obesity in this country, is a worldwide epidemic.
Okay.
And so we needed a way to categorize what people would do well with surgery and what people do not do well with surgery. We utilize a measure called the BMI. body mass index. And the body mass index is a relationship of your height to your weight. And you come up with a number. Normal people, who I've never been a normal person, normal people have a BMI of 25 or less. Your BMI is probably about 25. 25 to 30 is considered overweight. 30 to 35 is considered really overweight. And anything above 35 is considered obese. It is those people who have a BMI of 35 or greater that are considered for surgery. Okay. All studies have shown that people with a BMI of 35 or greater, 90% of the time will fail diet and exercise. It is those people with a BMI less than 35 who diet and exercise work 90% of the time. So one of the biggest problems is the stigma of being obese. We all have family members who are obese, and everybody at home says to them, oh, if you just push away from the table and act like me, you'll be skinny. But that's not true. And these patients fight this throughout their lives. They fight the stigmata that they're lazy, that they're unintelligent, that they just don't want to do it. But we know that for people with a BMI of 35 or greater, diet and exercise and just pushing away from the table or just saying no does not work for them.
Okay, all right. Is there a difference between men and women when it comes to being obese and the ones that get this type of surgery?
Well, men and women, their obesity patterns are different. Men tend to get their obesity only in the trunk, from the breastbone down to the waist.
You're trying to say a pot belly? Is that what you're trying to say?
Sort of say a bowling ball on stilts. That's what I'm saying.
Okay.
Women, the obesity tends to be more global. Women tend to get in their arms, in their buttocks, in their thighs, and in their belly. But men, it tends only to be a central problem. It is much easier to operate on on a female than it is on a male. The anatomy is just different. The male tends to lose weight faster than the female, but 80% of my patients are females. It seems that men, it's socially acceptable for men to be big. But for women, it is not socially acceptable for that.
Is there a difference in race as far as, obesity and the surgery and how the surgery is done or anything like that?
There are multiple causes of obesity. And one of the major causes is genetics. So race is a factor of genetics, or genetics is a factor of race. So therefore, in lower socioeconomic populations, Latino, African American, we tend to be more obese than the general population. It is also more difficult for the African American to lose weight because this was a survival mechanism for us on the Great Passage from Africa, that we survived because we were able to retain salt, we were able to retain water, and we were also able to retain fat. So it was a survival mechanism for us.
I've always been told, and I don't know if this is a fact, maybe you can clarify this for me, that African Americans may have more muscle than fat compared to other races, so that we may be heavier even though we may be the same height and body structure. We may be a little heavier because muscle is heavier than fat cells.
Well, there is a genetic difference between African Americans and Caucasian Americans. And it's interesting enough that the Latinos, depending on what part of the world they're from, do they mirror, whether it's Caucasians they mirror or African Americans that they mirror. Argentinians, for example, would mirror a Caucasian population. But as we've now had greater immigration from the Slovak nations, we are seeing that same trend in the Slovenian type population as we see in African Americans. Very dense muscles, very light fat, but definitely higher weight compared to their height.
All right, good. Are there age limits? Who's too young, who's too old to have the surgery?
There are no absolute age limits. What there are physiologic limits. The oldest patient I have operated on is 76 years old. The youngest patient I have operated on is 17 years old. And the reason 17 is a cutoff, that's because of insurance considerations. There are multiple studies going on now about childhood obesity. Childhood obesity is going to be the greatest scourge to this nation in the next 25 years. We are having children who now are so overweight that they are going to have diseases we have never seen in children before. Those diseases include retinopathy from diabetes. We're going to see back pain, arthritis. We're going to see kidney failures. We're going to see heart disease in 30-year-old individuals, which before we have never seen.
Okay, all right then. And one more question. Is it more risky, the surgery, is it more risky the larger you are?
Well, all surgery is risky.
Okay.
Bariatric surgery by its nature is very risky because the patients themselves are functioning at maximum capacity. There's something called the therapeutic index. How much you do can be good versus how much you can do that is bad. You take, for instance, a drug like aspirin. The therapeutic index is wide. But a morbid obese patient, the therapeutic index is very, very narrow. So the surgery is risky. What I tell my patients is that you come in and you're like a 65 Chevy that hasn't been kept up. What we do is make you the best running 65 Chevy on the road prior to surgery. Once we do the surgery, we try to get you to be a 2013 Mercedes-Benz.
I hear you.
That's what we do.
Now, when this patient presents to your office, what exactly do you do to prepare them for the surgery? Do you have to send for different consults, or do you have to do a physical exam? What do you do, to that patient to get them ready? Tell me what happens.
Well, it's a multi-stage process. The first thing we do is have a large meeting in which we explain exactly what we're talking about here, bariatric surgery. And then from there, the patient comes to the office for an individual consultation. I do a history, an extensive history of all their past medical problems, all their past surgicals, and any other problems they may have. Physical exam, and then we talk about their desires, what they think they might want, what their fears are, what their wishes and desires may be, where they want to go in their life. And then I present the surgeries to them. In order to get the surgeries done, they have to have a nutritional consultation because we have to teach them not only what to eat, but how to eat. For instance, you must chew your food 18 times prior to you swallow. How many times do you chew your food?
Probably two.
Two. And if it's a slice of hot pizza, maybe one.
You got it.
So we have to give them things that are going to support them for their success as life goes on. We also have a psychological consult because 80% of people have some form of depression associated with their obesity. Think about it. We have a society that is geared against obese people. You can't go to the amusement park. You can't ride the rides. They want to charge you twice to ride an airplane for 2 tickets, which is illegal. So we have to give them the support structure because once they change their weight, we have limited the amount of food they're going to be able to eat and what is going to be the thing that they utilize when they have a problem. Typically now it's eating to comfort them. So what are they going to do? We have a 20% chance of people switching from food to drugs, alcohols, and some other destructive type behavior. In addition to that, this is where you come into play. They have to see the pulmonologist because they have a high incidence of sleep apnea, which must be corrected prior to surgery, which ensures great results. 20% more for a person who is treated with sleep apnea than a person who is not. They get a 20% greater reduction in weight. Then they have to have a gastroenterologist see them. Because
that's a stomach specialist.
That's a stomach specialist.
All right, you're throwing out these big words. I mean,
they have to have a stomach specialist. We want to make sure that there are no problems in that stomach because once we do surgery, it's going to be hard to get back into their stomach again.
Right.
And then there's a set of lab works. The number one complication with bariatric surgery is decreased vitamin levels. Most people think it's going to be death. Most people are going to think it's infection, but it's actually decreased vitamin levels. So we want to get a baseline of where you're at and keep monitoring you as you go forth.
Okay. Just to be clear, you mentioned obstructive sleep apnea.
Right.
And patients may not understand what that is. Do you want me to handle that one? Or?
I was getting ready to field that one back to you. Okay.
All righty. Well, obstructive sleep apnea, basically what it is it's that because you're obese, the airway actually is maybe just a little bit narrow. And when you actually go to sleep, the soft palate or the back of your throat actually falls back and covers your airway such that you cannot breathe. And there are episodes during the night that you stop breathing and the oxygen actually dips very low. And over time, this can develop into significant heart disease. It can develop into significant lung problems. And an obese patient that post-surgery, it's very important that we understand how tight their airway is, because they must be, once we take out the intubated tube or the tube that breathes for you during surgery, we must allow you to breathe and make sure that you can breathe. So we need to know that prior to surgery, just to let you know.
Okay.
All righty. In the U.S., just give me an idea, and this will be my last question because I want to get to those excellent pictures that you got. In the U.S., how many people in the U.S., I know we have a bad problem with obesity, but about how many people are obese or overweight in our particular country?
Well, again, it's a worldwide problem.
Mm-hmm.
In the United States, it's estimated that 32% of people are obese.
Oh.
In New Jersey, the number is more like 37% as opposed to the 2011 census. Mm-hmm. 37% are obese and are candidates for obesity surgery. Mm-hmm. Now, a couple of facts about this obesity. If you take an equal weight person, the same intelligence, the same sex, the person who is not obese makes about $15,000 more a year than the person who is obese. And that comes from lost days at work, cost of medication, cost of clothing, and the increased cost of food. So you want to save $15,000, let's do something to lose the weight.
I hear you.
Okay.
I hear you.
What I did do is bring some diagrams of obesity surgery.
All right, excellent. Let's see those.
The first one that we're going to talk about here is what is called lap band surgery. It's very popular, but has been decreasing in popularity over the years because of the effectiveness or lack of thereof. Essentially, we take the top of the stomach and we put a band around the stomach. Underneath the skin over here is a reservoir. And that reservoir, you can put increments of saline in it and blow up the lap band. What I did bring was a sample of a lap band. Now, a lap band is a silastic piece of plastic which is introduced into the belly open like this. It goes around the top of the stomach, and here is an inner tube. This goes around the top of the stomach. We secure it in place by pulling this through, and it's secured over the top of the stomach like this. It's attached to this port, which is put under your skin right here. By filling saline up, we blow up this balloon right here, and therefore it constricts the stomach, and therefore minimal amount of food can go in. Mm-hmm. So that is a lap band. With a lap band, you'll lose about 50% of your excess weight at about 3 years. Mm-hmm. So if you're 100 pounds overweight, you expect in 3 years' time you'll lose 50 pounds.
Now, let me just go back before we leave this one. I know I want to cover all of them, but what you're saying is that we're putting actually like an inner tube around the top of the stomach.
That's exactly what
we're blowing that inner tube up and narrowing things.
We're squeezing it
so
down.
So that when the food goes down, it has a hard time to get through.
Yes, you cannot eat egg rolls.
All right. Okay. I got you. All righty. All right. Excellent. Go ahead to the next one.
The next one is the gastric bypass, which again is the gold standard. We essentially take the stomach and divide the stomach with a stapling device. The stomach turns out to be about the size of a small egg, hard-boiled egg. Okay, thank you. We then take the intestine and cut the intestine and bring the intestine up and attach it to that pouch. So the two effects of this one, it restricts the amount of food that can go in. You can probably only get about 3 baby spoons of food into that. And then the food passes through a lot quicker, so you don't absorb it. So with this operation, at a year's time, you'll lose about 90% of your excess weight. So if you are 100 pounds overweight, you will lose 90 pounds in about a year's time. Very minimal complications. Again, the biggest complication is decreased vitamin levels because people do not take their vitamins for some reason. Now, there is a third option. And that third option is a sleeve gastrectomy. What we do with a sleeve gastrectomy is we come to a point on the stomach and we staple and cut the remaining 2/3 or 3/4 of that stomach. This part is the part that distends. This allows the guy, the Japanese guy who eats the hot dogs at the Nathan's contest, to eat 40 hot dogs because this extends. And then it also stores it. So not only do you eat a lot, you absorb a lot. We remove this portion of the stomach and create a sleeve of the stomach. There is no intestinal portion of it. There's no malabsorption. It's just a restrictive procedure. Therefore, you lose something between what a lap band will lose and a gastric bypass. It's about 70% at 1 year's time. Very low complications. The interesting thing about sleeve gastrectomies, when we do these surgeries laparoscopically, the patients go home the same day, as well as with the band. The gastric bypass, you stay in the hospital maybe 2 days. So these are the surgical procedures that we advocate and that we push forward for patients.
Okay. Now, you had mentioned the word several times that I just want to clarify, absorption. And when you say absorption, what do you mean? Do you mean that certain nutrients are go into the cells of the intestinal tract or the stomach, or tell me what absorption really means?
Well, everything that one takes into the body is broken down into sugar. The certain things that you have cause certain amounts of absorption. So essentially, absorption is bringing those sugars into the stomach.
Mm-hmm. All right then. So what we're talking about is you still are able to absorb fats.
Yes.
And your proteins.
Yes.
So you still have a normal complement of nutrients coming through, or the things that your body needs to work off of. You can still get those in.
Yes.
All right then.
At times, we have to add things to that. Like certain vitamins will not be absorbed the normal route. You have to take them under your tongue.
Okay.
That's all.
Now, I know that certain diseases are helped with gastric bypass because of the weight loss. And just to go into some of the diseases that may improve. I know as far as lungs are concerned, obstructive sleep apnea, actually that's one of the treatments for obstructive sleep apnea is weight loss because it opens up the airway. But what are some of the other things that may improve just because you lost the weight?
It is almost miraculous. Night and day. The sleep apnea goes away within 30 days. The diabetes, type 2 diabetes, with bariatric surgery, you get a 99% cure rate, 95% cure rate for high blood pressure, 90% for arthritis, et cetera, et cetera.
All righty. Well, you know, there is so much more that we could talk about as far as this subject is concerned. I'm just enjoying it immensely. You know, the fact that there are so many people that can be helped within this country and around the world by this procedure, it's just so great that we can offer this as physicians. And I'm excited that you came and you explained it to us, and basically you let us know it's from, you know, like from A to Z what gastric bypass is all about. So again, thank you for coming on the show. And
thank you for having me.
Yes, and we'll have to have you back, and we'll have to pick another topic because it's all good.
Okay.
All righty. This is our Let's Talk segment. And I just wanted to cover a few things. Basically, I wanted to cover heart attack and stroke. And the reason I wanted to cover those two is the urgency. If you feel that a family member or a friend or someone at the job or even yourself is having either a heart attack or stroke, you must call 911. The reason you must call 911 is because Time is of the essence. What happens is, as the quicker you can get that particular patient to the emergency room, the more likely you're going to be able to save their life or have a full recovery. As far as heart attacks are concerned, you think about things like chest pain, you think about shortness of breath, you think about pain in your jaw or your left arm or your stomach. These are type of things that you kind of listen for, that the patient is complaining about, that you would want to call 911. For strokes, what we're talking about is a facial droop on one side, having difficulty speaking, such slurring of the words, and also things like if you have weakness in your arms or your legs on one side as opposed to the other. These are some of the things that you look for in a stroke. And if you find these in anyone, you're a coworker or a family member, then you must call 911. Okay, it's been a great show, and I'd love to stay longer, but we got to go. So in closing, remember, sharing and caring, www.medmoments.com. Email me. Let me know what's going on out there. And so we can tweak the show and put on what you want to see. And we'd love to do that. Also, you can tweet me at MedMoments. Never institute any change in your medical therapy until you consult your physician. I trust that each and every one of you have continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.